بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. ما زلنا مكملين European Society of Vascular Surgery guidelines for the management of acute limb ischemia, and today we'll discuss the last point in the specific considerations, which is a summary for what we said before and decision-making algorithm in acute limb ischemia. Then what about the post-operative medical treatment and follow-up? What is the follow-up after arterial embolization? What is the follow-up after native arterial thrombosis or occlusion of an artery treated by endovascular or open surgery? And what is the follow-up after thrombosed popliteal artery aneurysm? As regards the decision-making algorithm in acute limb ischemia, when acute limb ischemia is suspected, referral to a 24 full vascular service is recommended, and by full we mean a vascular service that can provide both open and endovascular options for the patient. And if acute limb ischemia is confirmed clinically, immediately we should start heparin plus oxygen plus the analgesia, and then put the limb in the Rutherford categorization to either 1 or 2A or 2B or 3 irreversible. And according to this categorization, we can either do a conservative treatment as in chronic limb ischemia, or to do an urgent imaging. It is better to do the CT angiography or a duplex ultrasound or the MRA, and selection of the best treatment modality. And you have to think in a dynamic way to either choose the endovascular technique only and to know when to convert to an open surgical option, or to choose open surgical technique and know when to convert or to combine the open surgical technique with the endovascular technique. Then to do a completion imaging, to do either an open, hybrid or endovascular treatment of the underlying or residual lesion after treatment of the acute cause. And in this algorithm, actually we need to see as regard the class 3 in irreversible acute limb ischemia. In patients with a short duration of motor deficit, there is a small chance of limb salvage. In very selected cases, urgent revascularization can be considered, and this, as we know, is one of the main drawbacks, or of the many drawbacks actually, in Rutherford classification of acute limb ischemia that needs an improvement in future. What about the post-operative medical treatment and follow-up? And this is mandatory in cases of acute limb ischemia. And this is due to the high rate of early and late limb loss, as well as the considerable mortality following treatment of acute limb ischemia. Those things are the indications for follow-up after treatment. This may include both the patient's cardiovascular condition and an assessment of the functional status of the limb. So what are the main items of the follow-up? The cardiovascular condition of the patient and the cardiovascular risk factors of the patient. And the other thing, after treatment of the acute limb ischemia, what is the functional status of the limb? Is it recovered by 100%, so a full recovery, or a partial recovery? And what about this partial recovery? This partial recovery will be a permanent disability to the patient, or it will improve by time. What about the follow-up after arterial embolization? As the most common causes of arterial embolization are the atrial fibrillation and intracardiac thrombosis, one of the most important aims of post-operative management is actually the prevention of recurrent embolization. And to prevent a recurrent embolization, we have to know the source of embolus. And for evaluation of all of these conditions, we need to do either an ECG or other diagnostic modalities to identify acute myocardial infarction, 24-hour ECG monitoring when necessary and when paroxysmal AF is suspected, as well as echocardiography and CT angiogram even of the whole aorta if no intracardiac embolic source is identified. The value of anticoagulation for prevention of embolization in patients with AF is well established. So what type of anticoagulant to use? Recurrent limb ischemia was less common in patients given warfarin initially, 7% versus 17%, and still taking the warfarin after 1 year. So actually the warfarin provides a good prevention of recurrent embolization either initially or after 1 year. And due to this cause, actually warfarin has been the most commonly used medication for this purpose for decades. Direct oral anticoagulants may decrease the risk of acute limb ischemia significantly compared with warfarin in patients with atrial fibrillation. Early heparinization also is a modality that can be used after the surgery for acute limb ischemia, but there is no evidence of a benefit of short or long-term heparin treatment in patients with acute thromboembolic arterial occlusion. But it is reasonable to use the heparin as a short-term anticoagulant post-operatively, just in case you are planning to do another intervention. As for example, that you are watching the leg of the patient for compartment syndrome and then compartment syndrome happened, so it is reasonable to give a short-acting anticoagulant in the early post-operative period rather than starting a long-acting one. في العيانين بالذات اللي بيحتاجوا مثلا او اللي انت بتراقب فيهم هيحصل كومبارتمنت سيندروم ولا مش هيحصل كومبارتمنت سيندروم، انت ممكن تدي الشورت اكتنج انتي كواجولانت علشان لو هتعمل another surgical intervention. So what about the follow-up after native arterial thrombosis or occlusion of an artery treated by endovascular or open surgery? We need to know when dealing with these patients that we are dealing with a type of patients which are prone to repeated major cardiovascular events, often leading to their rehospitalization, reintervention, and even an early mortality. So, in patients with symptomatic peripheral arterial disease, acute limb ischemia is most often caused by thrombosis of actually diseased native vessels. And for these diseased native vessels, we need to control the risk factors and to modify the patient risk factors, either by acute occlusion of the native vessels or occlusion of a bypass graft or an endovascular procedure. Following the surgical or endovascular revascularization for the acute limb ischemia caused by the arterial thrombosis, regular follow-up may be beneficial for this diseased arterial bed, including clinical evaluation and assessment of the functional status of the limb, as we said before, and also specific studies addressing this issue unfortunately were not identified. During the follow-up visits, pulse examination and ankle brachial index measurements are performed, and if clinical symptoms deteriorate or there is a significant drop in the ankle brachial index, a vascular imaging, either duplex ultrasound or a contrast enhanced MRA or a CT angiography or even a digital subtraction angiography is required. وهنا لازم نقول كلمة مهمة قوي. لو العيان جالي ومفيش عنده clinical symptoms جديدة، يبقى ممكن أسيبه على الكونزرفاتيف مانجمنت. يبقى شروط إن أنا أعمل imaging في العيان في الفولو أب إن في clinical symptom deterioration أو إن في significant drop في الأنكل brachial index. What about a concomitant malignancy or thrombophilia? In any young patient less than 60 years of age affected by a thrombotic acute limb ischemia, and in particular when patients suffer simultaneous venous and arterial thrombosis, concomitant malignant disease, and or thrombophilia should be investigated post-operatively. So treat the acute condition first. Then if the patient has these criteria, he is young, the pathology is thrombotic, he has a history of both venous and arterial affection, please search for thrombophilia or malignant disease. Smoking cessation. Smoking is a strong risk factor for the development and progression of peripheral arterial disease. Several studies suggest that smoking cessation is associated with a lower rate of cardiovascular, ischemic, and limb-related vascular events, amputation, and even death. So patients who smoke should be advised to quit smoking not once, not twice, at every follow-up visit, and should be offered support for smoking cessation from smoking cessation team if available. What about the antithrombotic medication and the statins? As we know, thrombosis affects a diseased arterial bed or a diseased vascular bed. So the antithrombotic medication and the statins may improve this condition. Following the acute limb ischemia revascularization for arterial thrombosis, antiplatelet therapy and statins should be administered to decrease the cardiac complications and to prevent the atherosclerotic disease progression. Statins, as we know, were associated with improved infrainguinal bypass graft patency and reduced restenosis and amputation rate and protection from cardiovascular events. Long-term anticoagulation after thrombectomy or thrombolysis of an occluded prosthetic graft might be considered, and the combination of low-dose direct oral anticoagulants and low-dose aspirin, as in the cardiovascular outcomes for people using anticoagulation strategies, which is the COMPASS trial, has not been investigated after the acute limb ischemia. However, in patients with a stable peripheral arterial disease, an overall benefit from receiving a rivaroxaban of twice daily 2.5 mg plus the aspirin 100 mg per day was demonstrated, and as we know in the COMPASS trial, they found a decrease in both the major adverse limb events and major adverse cardiac events. Although the COMPASS trial was positive for patients with acute limb ischemia, this was not the primary endpoint for this study, and further research with a focus on the acute limb ischemia is needed. What about the imaging modalities? Actually, duplex ultrasound is the imaging modality of choice during the follow-up, and this is in contrary to the CT angiography, which was the preferred one in the diagnosis of the acute limb ischemia. It is non-invasive and most appropriate method to evaluate the degree of stenosis. There are no problems with artifacts after stenting. CTA and contrast-enhanced magnetic resonance angiography are alternative non-invasive tools for the follow-up. Contrast-enhanced MRA can provide a useful information on the remodeling process after the endovascular intervention and can also determine patency and restenosis if stents were not used. Duplex ultrasound surveillance after infrainguinal vein bypass in general, and not specifically after treatment of acute limb ischemia, has been advocated for over 20 years. However, the evidence of this practice remains contradictory. Duplex ultrasound surveillance compared with clinical examination and ankle brachial index measurement was not associated with a significant change in the vein bypass patency, amputation, or mortality. And this is the cause that surveillance by duplex ultrasound is not recommended with a very high grade of evidence. Many vascular surgeons offer clinical and imaging follow-up after 4 to 6 weeks, then 3 and 6 months, 3 months and 6 months, and 1 year and 2 years after the bypass surgery. Follow-up after the thrombosed popliteal aneurysm. As we said before, patients with popliteal aneurysm have an increased risk of new aneurysm formation in the contralateral popliteal region, the aorta, and at other locations. These patients should be followed, and if a new aneurysm develops, a vascular reconstruction should be considered to predict the life and the limb. It would be adequate to re-examine the normal arterial segments every 3 years. A similar follow-up approach can be recommended after. There are no data, unfortunately, to support the duplex ultrasound surveillance improving the outcome. So if duplex ultrasound detects a severe restenosis, an endovascular intervention or open surgery is recommended. What about the recommendations from the guideline? After revascularization for acute limb ischemia, follow-up should be considered, including the patient's cardiovascular condition and functional status of the limb. So these are the goals of the follow-up of the patient. Do not forget the general condition of the patient, the cardiovascular condition of the patient, and do not forget about the function of the treated limb. For patients revascularized for acute limb ischemia of embolic origin, it is recommended that whenever possible the source of embolus be investigated, and this is to prevent a recurrent embolization. After revascularization for acute limb ischemia caused by an embolus secondary to atrial fibrillation or an intracardiac thrombus, long-term anticoagulation is recommended. For patients who have had a revascularization for acute limb ischemia of embolic origin, long-term anticoagulation may be considered for patients without atrial fibrillation or intracardiac thrombus. Antiplatelet therapy or anticoagulation and statins are recommended long-term to reduce the cardiovascular events following acute limb ischemia revascularization caused by native artery thrombosis or a thrombosis of a popliteal artery aneurysm or failure of previous revascularization, either open or endo. For patients treated for thrombosed popliteal artery aneurysm, regular duplex ultrasound follow-up should be considered after open or endovascular surgery, and for patients treated by open or endovascular surgery for a thrombosed popliteal artery aneurysm, duplex ultrasound imaging of the treated and to the contralateral arteries as well as the aorta, iliac and femoral arteries every 3 years should be considered. Long-term anticoagulation may be considered after thrombectomy or endovascular treatment of a prosthetic bypass graft occlusion.